General physician, and I am Anna Fox. I'm a third-year resident in Magic Valley, which is Twin Falls and Jerome. And I have been working for the last couple of years just here and there with the HIV clinic that is put on here in Twin Falls. Dr. Stacy Lamers comes from Boise. We have case management from Family Health Services here in Twin Falls. And then Dave Hatchie, pharmacist extraordinaire, coming from Pocatello as well. And so I've gotten to work with them over the past couple of years. So what this is a broad overview. I am not an HIV specialist. I don't have a fellowship. So it's a broad interview to introduce or reiterate important things to keep in mind in general practice and screening for HIV, treating HIV, providing primary care for patients with HIV, and resources for all of us to know about in primary care. What it is not is hugely detailed, a lot of AIDS information or AIDS management, a lot of nitty gritty detail in antiretroviral therapy, although we will talk about antiretroviral therapy. I think it's a little more high yield to work on that on your own, maybe with some of the resources that we'll discuss. So without further ado, these are our learning objectives. We'll talk about screening, testing. Basic prep is just going to be sprinkled throughout. You're welcome to turn on your microphone and answer the prep question if you can also tell us about the work of art on that slide. If that is not working well, as Liz said, kind of questions at the end, I'll answer the questions for you, but that's an option as well. And then we'll talk about initial management of HIV, primary care for patients with HIV. So you might not be comfortable prescribing antiretroviral therapy, but you will certainly be expected to provide primary care to patients with HIV. And then resources, local and national, and how to stay informed about HIV care. So epidemiology, or why are we talking about this? There are quite a few people with HIV, living with HIV in the United States. And between 2017 and 2021, every year, 20,000 new diagnoses with HIV happened in the United States. And 1/5 of those already had AIDS, which is unacceptable. So many complications can be avoided if patients never experience AIDS. So we'll talk about how we can avoid that. In Idaho, unfortunately, there was the higher rate of 26% with late HIV at the time of diagnosis. In 2021, 1,300 people in the state had HIV. And here at the bottom on the right, you can see that the majority of our HIV positive population is over 55. So more likely to have comorbidities, qualify for your typical health maintenance screening. So all the more important for primary care physicians to be comfortable managing their care. So screening, both the CDC and USPSTF only vary slightly, but recommend everyone be screened at least once. So either starting at 13 or 15. And in spite of this, in the 10 years it was studied, only 40% of non-institutionalized adults had ever been screened for HIV. So that's something that we should want to change in the state of Idaho. Pre-screen counseling, I do talk to my patients when I'm offering them screening for hepatitis C and HIV just as part of their health maintenance. I do talk to them about a false positive rate, but it is very, very low. And then of course, increased screening for increased risk individuals, IV drug use, patients coming in requesting sexually transmitted infection testing, etc. And then of course, during every pregnancy, pregnant patients should be screened for HIV. So PrEP. If anybody wants to pipe up and say who can prescribe PrEP and what is this artwork, you're welcome to. If not, I'll just go on through it. Anybody, any takers?
Anybody can prescribe PrEP, and this is Vincent van Gogh after utilizing mushrooms.
Okay, so close, so very close. This is Cairo, and it is from the illuminated manuscripts of the Book of Kells in Trinity College Dublin in Ireland. And yes, you can prescribe PrEP. You should recommend and prescribe PrEP pre-exposure prophylaxis for anyone at increased risk of acquiring HIV, and that you might just find on your board questions. I did on my board exam. All right, so we talked about screening asymptomatic patients. We'll talk about testing symptomatic patients, patients with exposure, patients with a positive screen. So for an acute or recent exposure, we have the nucleic acid test. So that's going to be looking for actual virus, and that's going to be positive much earlier than an antibody-associated test. The HIV diagnosis requires 2 positive tests of 2 different types, as stated here on the right, where we also see testing options. Most are self-explanatory. I did include a visual of the P24 antigen here, which is a surface protein of the viral capsid. So in case anybody didn't know what that is, there's a little diagram there for you. And then you can see the antigen antibody test and antibody tests are, especially the antigen antibody test is great, but it's just if you're really concerned about this being an acute exposure, not likely to help you as much as the tests looking for actual virus. And then just wanted to note here too, the post-exposure prophylaxis. So you have a patient come in concerned about exposure. You can definitely consult and get more input on that, but you definitely want to start your post-exposure prophylaxis antiretroviral therapy well within 72 hours, and the earlier the better. So now you've tested for HIV, made a diagnosis with a test and a confirmatory test, and you don't need to panic. Based on my experience, you'll find nothing but really knowledgeable physicians and pharmacists who are eager to help in the local context that we'll talk about later. But here is a place to start. We'll talk about history, counseling, and labs. So I have squished in new patient and prior diagnosis into this too, because maybe you'll have a patient come to you, new patient to you, but says, hey, I have HIV and I've had it for a while. So we want to get the date of diagnosis if they have had an HIV diagnosis before, approximately when they think they might have acquired the virus, and then prior complications, opportunistic infections, malignancies, tuberculosis exposure, and then really important to know about past exposure to antiretroviral therapy. Many patients might be coming new to you with this new diagnosis from abroad, for example, and often there are different therapy options abroad. And then you want to know what they were on and why they may have changed over time. And then, of course, what PrEP use they might have had. Like, even if this is a new diagnosis of HIV, they might have been an at-risk population and receiving prophylaxis prior to their infection. And so wanting to know what type that is, and we'll talk about that more a little bit later. Of course, past histories, family history, psychiatric history is important. Of course, in the general population, then HIV can contribute and antiretroviral therapies can contribute to mental health issues. Sexual history and practices, not to be nosy, but to be able to risk stratify patients and best care for them. And then immunization, substance use history, and social supports. Social supports is really important. You want to know if your patient has rides to get to their appointments and their labs, if they have enough money or insurance coverage for antiretroviral therapy. And then, of course, a thorough physical exam focusing on oropharynx, skin, lymph nodes, anogenital area as patient consents to that. All right, and then counseling. So knowing a little bit can be super helpful and reassuring to patients. We want the patient to leave the visit feeling okay, at least, about their prognosis, if not good, and motivated to stay engaged in care. That is super important. So first listed is financial assistance is available. So making sure that if you have a patient come in, that you know that you can tell them that they will have specific financial aid for them having HIV and for their HIV treatment. We had a patient come to the HIV Wellness Clinic in Twin Falls who had just paid like upwards of $4,000 for their first antiretroviral therapy prescription. And because they weren't linked in with financial assistance, I'm not sure they ever got any of that back. And it really shouldn't break the bank. Like, it should be a negligible cost for most people. Then reassuring the patient, many are living long, happy, healthy, fulfilled lives with HIV. HIV, and more treatment options are expected to become available all the time. So we have single tablet regimens once daily. No longer is nearly anybody taking like multiple tablets multiple times a day. And then there's now a monthly, which changes to every 2 months, injection as well. So long acting injectable for people who can't or just don't reliably take a medication every day. And then U equals U. So undetectable virus is untransmissible. So important for patients to know if they're on viral suppressive therapy and they have undetectable virus that they cannot transmit the virus, even by sexual contact. Of course, still important to use barrier methods and protect from sexually transmitted infections, et cetera, but really important for patients to know that they can still have a healthy relationship. And then, in spite of that, in Idaho, it's law that patients with HIV must inform sex partners of positive status prior to having sex with them. And so that's just an important thing for patients to know, that they won't likely have known coming in to talk to you unless they're very informed about HIV law in Idaho. And then just reminding patients it's really important to stay engaged in care, and to be regularly taking their antiretroviral therapy, just like any other antimicrobial that we think about. Um, the incomplete courses or subtherapeutic levels can contribute to resistance, and this is definitely the case with antiretroviral therapy. All right, so labs, I know this can be a little bit daunting, so I've kind of tried to separate it out. The three first are highlighted. So viral load and CD4 count and viral genotype are really important to get, but you do not need to delay antiretroviral therapy to get the genotype result. That can take about 2 weeks. And so it's really important that we get that lab test and that you are sure that the lab collecting it is like knowing what they're doing and everything. But once that is collected, it is definitely fine to start antiretroviral therapy and not wait the 2 weeks that it could take. Other infections need to be looked for: Toxoplasma gondii, tuberculosis, syphilis, hepatitis, and then pregnancy tests, gonorrhea, chlamydia, trichomonas. And then baseline complete blood count, you're going to use that for your CD4%. CBC, CMP, you're looking at your creatinine clearance, ALT, AST, and glucose, UA, lipid profile. Really important to have baselines of those because a lot of different things can be affected by antiretroviral therapies. And so we need to know if that's due to the therapy or previously present, possibly due to the virus, et cetera. Not routinely recommended labs are at the bottom here, so they are required in certain circumstances, but for most primary care providers, you're going to be starting like Biktarvy most likely, and it's just important to talk with an expert about other antiretroviral therapies and what additional testing might be expected. So let's talk about antiretroviral therapy. So this is not meant to be scary at all. I'm very visual, so I wanted to describe it in a way that I find helpful. And if it's just terrible, you can ignore it and we can just talk about the names, but for some, this could be helpful. Just wanted to reiterate here that it is usually appropriate to start antiretroviral therapy in the primary care setting. So here's overview of HIV and therefore where our drug targets are. So we see here the HIV virus binding the surface receptor of the CD4 cell and inserting its genetic material, the RNA, along with the enzymes that it carries inside its capsid. So it brings in its RNA and uses its own reverse transcriptase to reverse transcribe into DNA, which then can be integrated with its own integrase that it brings with it into our human DNA, and then can use the human enzymes just because it's doing a normal DNA to RNA transcription and translation to proteins. And then it uses its own protease that it brought with it to do cleaving and maturation so that it can go forward with additional viruses, infect additional cells. So this is where our drugs can target because these are viral specific enzymes. So our reverse transcriptase um, inhibitors prevent that change from RNA back into DNA so that then there's nothing that can be integrated, right? And so those are going to be like the emtricitabine alafenamide or tenofovir alafenamide parts of Biktarvy. And then the integrase inhibitors or integrase strand transfer inhibitors prevent that integration of the newly made viral DNA into DNA. And then the protease inhibitors are going to prevent the cleavage and budding maturation um, last steps of the viral life cycle. So here we have typically an anchor, and that's going to be an integrase inhibitor or a protease inhibitor, and then a backbone typically of a reverse transcriptase inhibitor. And so the initial treatment often is going to be that integrase inhibitor backbone. So that's bictegravir and Biktarvy, and then the reverse transcriptases, emtricitabine and tenofovir alafenamide. If the patient has been exposed to PrEP in the form of cabotegravir, you can see the tag in the middle of that drug name. So that's an integrase inhibitor. Then they have the potential of their virus having a resistance to integrase inhibitors. And for those patients, often we're going to be starting them on a protease inhibitor anchor instead of the integrase inhibitor anchor. And then also just wanted to highlight it's really important to start antiretroviral therapy quickly if you're concerned that a patient has acute HIV or recent exposure, because that's when their viral load is going to be very high and transmission is going to be very high, and they could have immune suppressive complications. Another thing to highlight is just like our single tablet regimens all have multiple mechanisms of action inside of them, increasing efficacy and reducing resistance. So even though things have simplified as far as number of tablets, number of times a day, they're still containing multiple different mechanisms. Biktarvy is far and away the most transcribed or the most prescribed, in the state of Idaho. And that is a very well tolerated medication, works really well, increases as far as side effects can increase bilirubin up to 17% of patients, but otherwise very well tolerated, has some GI symptoms, rash. We had a couple of patients strangely at similar times have rash side effect to Biktarvy, which resolved when we switched their medication. And then you can also have neutrophil suppression. But overall, very well tolerated medication. All right. So a little extra information just to highlight options for acute and recent exposure HIV treatment and reiterate that genotype testing is very important, but need not delay antiretroviral therapy for results from the genotype testing. So just wanted to include here the different options if you're not able to get a hold of someone, and we'll talk about how many different ways you can get a hold of someone, and that should never happen, but just in case you have your options for acute or early HIV here. And then just stated another way about thinking about changing your initial management of antiretroviral therapy if the patient has exposure to PrEP in the specific form of cabotegravir. All right, so more PrEP. Question, what antiretroviral therapy can be used for PrEP, and what is this work of art? Any takers? Okay, so I'll just go ahead. This is Sagrada Familia Antoni Gaudi. It's in Barcelona. And these are the different antiretroviral therapies that can be used for pre-exposure prophylaxis. So Truvada, Descovy, Apretude is an injection. That's cabotegravir, the one that we've been talking about. If patients have exposure to, then they would have a little bit different initial therapy if they did acquire HIV, which they most likely would not because they're on pre-exposure prophylaxis. And this is the Trevi fountain, which I learned recently is made out of the same materials as the Colosseum, which I didn't know before. And that is in Rome. Okay, HIV and pregnancy, obviously another huge topic, but my purpose here is to highlight a few things, mainly that we can all help contribute data. And so just a little bit of information about a reminder in pregnancy. We need quite a few pregnancies information in order to detect significant, even pretty significant changes in overall birth defects. So we can report if you have any patient who has an HIV positive status and becomes pregnant, you can report that into the antiretroviral pregnancy registry. And then certainly also any interesting or different events that occur with the pregnancy, any adverse events related to antiretroviral therapy should also be reported. And then here are some examples of preferred therapies in pregnancy. There are multiple different options. The important thing is it's a risk benefits profile. So no one medication is completely safe and without any adverse events, but it should be individualized to the patient. And patients with HIV in pregnancy should be linked in with expert care. I added Biktarvy at the end. Thank you to Alyssa, our pharmacy resident, for reminding me that this is a newly alternate in pregnancy, but not a first line preferred medication in pregnancy as yet anyway. Considering continuation of care postpartum or others with childbearing potential, there is guidance on contraception use in HIV positive patients. Most contraception is safe with HIV and with patients with HIV on antiretroviral therapy, including hormonal options, pills, injectables, IUDs. But some antiretroviral therapies and certain hormonal contraception can affect each other's level. And so it's important for close monitoring and making sure that you're using the prescription resources for responsible prescribing with that as well. So we have about 4 slides now on just general primary care for patients with HIV. So patients with HIV have higher rates of multiple comorbidities. Cardiovascular disease is obviously a big one. Statins are recommended at a lower threshold, so ASCVD risk score of 5% major events in the next 10 years, lower than the 7.5 to 10% typically. So you're going to be recommending a statin at that earlier stage typically. And then under 40 years of age, it's having a shared decision-making risk-benefit discussion with the patient and considering their other risk factors. So you're considering traditional risk factors, then also metabolic syndromes and changes associated with antiretroviral therapy, and then also the HIV immune activation and inflammation. All of these things are contributing to that increased risk of cardiovascular disease. And then also in patients with HIV, higher rates of osteoporosis, of renal disease, testosterone deficiency, smoking, and I just made a note, varenicline is safe with antiretroviral therapy. And interestingly, for patients with HIV, rather than the general population where men smoke at a much higher rate than women, it's about equal in patients with HIV as far as men and women smoking status. And then anemia and thrombocytopenia, and always wanting to consider behavioral comorbidities. For example, substance use disorder might be more likely in patients who have acquired HIV through IV drug use or something of that nature. Dental care is very important for general health and well-being and self-confidence, but also there are HIV specific related periodontal diseases to consider. Regarding immunizations, you're going to have a better immune response typically at a higher CD4 count, but it's generally not recommended to delay vaccination. So even if the patient has lower CD4 count, you don't necessarily want to wait for them to be protected, except of course, in the case of live vaccines, which can be dangerous at a lower CD4 count. All right, this is our third slide about primary care in patients with HIV. So screening, you're going to have some of the typical health maintenance screening that you have for the general population. like colon cancer, breast cancer, abdominal aortic aneurysm, and lung cancer. Um, with in patients with HIV, they do have higher rates of death due to certain cancers like anal cancer, liver cancer, lung cancer, or pharyngeal cancer. But as you can see, there wasn't enough data, or there aren't guidelines to change the guidelines around lung cancer for this population. So there's no change into that screening schedule. But where the HIV population does have difference is in osteoporosis. So main things are you're going to be screening younger and certainly men at a much younger age. So all postmenopausal women and all men over 50. And then thinking about other risk factors from age 40. For example, antiretroviral therapies can certainly increase the steroid toxicity. And so if patients have extended exposure to steroids of any kind, then you want to take that into consideration and just have a much lower threshold for DEXA screening in these patients. For diabetes, HIV alone indicates screening. So when you're considering like your younger patients with overweight and not a super hugely high BMI and not a significant family history, the HIV alone might still be enough to indicate screening. Sometimes A1Cs can be underestimating, and so it's a good idea to get fasting glucose for initial screening. And then cervical cancer is quite different. Cervical cancer, non-Hodgkin's lymphoma, Kaposi sarcoma are all AIDS-defining cancers. And so cervical cancer risk is going to be higher in patients with HIV. You want to do your typical screening start of 21 years of age, but certainly screening with a PAP at the time of HIV diagnosis and at 12 months after that initial PAP. And for under 30 years old, you want to do a PAP yearly. After 3 consecutive normal PAPs, you can go to every 3 years. And then over age 30, you can do the same. Or if you're doing PAP with HPV co-testing, you can move that to every 3 years. And if you ever have high risk HPV 16/18, then the patient needs a colposcopy. And there are other indications for colposcopy that mirror more kind of the general findings in cytology for the general population that would indicate that. Otherwise, anal cancer is more common in patients with HIV, as I mentioned. If the patient has HIV and anal receptive intercourse and access to treatment, then the IDSA guidelines are recommending an annual anal PAP without HPV co-testing. And then I just wanted to highlight, because I forgot to say, we talked about increased risk of, or increased percentage of deaths due to anal, liver, lung, and oropharyngeal cancer. With breast, colon, and prostate cancer, there is no increase in death rates due to those cancer in the HIV positive population compared to the general population. All right, fourth and final primary care slide. So this is all about medication interactions, which are very common, unfortunately, with antiretroviral therapy. Part of that is due to a heavy reliance on the CYP3A metabolism in the liver. And obviously, there are quite a few different medications that can increase or decrease that metabolism rate. And then myriad other reasons for interfering, like absorption, et cetera. But we have, I included this resource at the bottom, the University of Liverpool. So we'll talk more about resources at the end, but just wanted to highlight that on this page too. If you're thinking of starting a new medication in a patient with HIV, or you're doing an annual medication review, it's a really good resource to use. And can give you a lot of explanation. So I'll have an example of kind of what one of those looks like a little bit later on, but good for responsible prescribing. So we have calcium, other minerals and supplements can affect absorption. So typically you want to space that out. Like if you're taking antiretroviral therapy in the morning, have patients take the supplements and minerals and things that could interfere with its absorption in the evening. Metformin, beta blockers, calcium channel blockers, antiarrhythmics can be increased to toxic levels with certain therapies. Simvastatin and lovastatin have increased toxicity and are contraindicated sometimes. Atorvastatin dose adjust Pivastatin and other um, statins are preferred in conjunction with antiretroviral therapy. Antacids can significantly affect absorption. Usually they can be separated, for example, like 2 hours before a patient takes their therapy or 6 hours after for certain therapies. For others, even like omeprazole, 20 milligrams daily, no matter when it's taken, is going to interfere. So it's important to know exactly which medications patients are on. Clarithromycin and rifampin reduce even Biktarvy efficacy. So important to consider those in our refugee population too, who come in on needing antibiotics. Azithromycin is typically okay, but should still be looked up. Steroids of any administration route can really have increased toxicity. So really important to keep a close eye on that and monitoring for signs of adrenal suppression, Cushing's syndrome. Hepatitis C antivirals can be increased and cause liver toxicity. Antipsychotics like quetiapine, SSRIs, tricyclics may be increased and need to be monitored carefully. And then anticoagulation and antiplatelets can increase and decrease the lead to bleeding or subtherapeutic levels where patients are clotting. And then anticonvulsants and St. John's wort reducing therapy efficacy. So these are just some illustrations of common things. And just important, like obviously there are quite a few medications here that might very frequently be prescribed in patients with HIV. So it's not to say you can't give them any other medications, but just having, just looking out for this especially. All right, back to PrEP. How often should patients on PrEP be seen? This is a little bit of a trick question. It's more the origin of the idea behind the artwork than the artwork itself, although I'd be very impressed if someone knows the actual visual artist here. So, any takers? How often should patients on PrEP be seen? Okay, I'll just go for it. So this is from The Great Gatsby, and F. Scott Fitzgerald. So patients should be seen every 3 months if they're getting prescribed PrEP, and they should only be given a 3-month supply at a time. You want to talk to them about their risk and exposures and determine what other conditions they might need testing for, and then testing for HIV every 3 months while on pre-exposure prophylaxis PrEP. All right, opportunistic infections. When CD4 counts are low, we need to consider protecting patients from these. Pneumocystis, pneumonia, or PCP, we need prophylaxis if CD4 count is less than 200 or 14%, or if it's less than 250 and the patient's not going to be able to get on antiretroviral therapy or is traveling and doesn't have access or something, and CD4 monitoring is impossible, because if we don't know that the CD4 count is not dipping below 200, then we want to protect them. Toxoplasma gondii encephalitis we protect against if the patient does have exposure to toxoplasma. And for both of these, PCP and toxo, we're giving trimethoprim sulfamethoxazole as the preferred. There are alternatives as well for patients who are allergic or don't tolerate that. And then for disseminated mycobacterium avian complex, we only prophylax if the CD4 count is very low, less than 50, and the patient is not on antiretroviral therapy and not about to start. Like if a patient comes in with a new diagnosis and a CD4 count of 30 and they're starting antiretroviral therapy, then we're not prophylaxing against MAC. And then histoplasmosis, we're not going to see a huge amount in Idaho just because of occupational and living exposures being so low. Primary prophylaxis is not recommended for everything, so certain things we're going to be testing for and seeing if they need specific treatment for that. But if the CD4 count is low, definitely seek expert help, which I am so excited to talk about very soon, because our next slides are all about resources and contacts, especially in the state of Idaho. So first of all, here is a little bit of information to reassure us or remind us all about the structure around access to HIV care. So there are Ryan White government grants through HRSA, um, and this allows for patients to have access to multiple services. Um, Keeping those grants, you have to have at least 75% core medical services and up to 25% support services. You have medical case management staff employed based on that funding. And then I talk a little bit here about, or list a little bit here about who can qualify to apply for these grants. And you'll see clinics and hospitals, anybody, nearly anybody who's providing early intervention services for HIV could potentially qualify to apply for these. And then there is the AIDS Drug Assistance Program, or ADAP. So patients will get medication coverage, go through the qualification process talking about insurance and income that they do or do not have, and what assistance is needed. And so most patients are going to be able to get what they need based on their needs. I don't know a huge amount more about this, so please do still feel free to ask questions at the end about it, but probably the best people would be talking to kind of the higher administration of the clinics that do have these grant funding. And they'll be able to talk to you much better than I could about how to get these grants. So my impression, which is very anecdotal, as I've very informally surveyed colleagues from around the state, is that if we are not directly and actively involved with expert HIV care, we really don't know who and what is available to us and to our patients. So I'm really excited to share this information. I'm hopeful that you can save it. And if you don't get the slides, you're always welcome to reach out to me to get this information. But in Northern Idaho, we have districts, health districts 1 and 2, and the North Idaho AIDS Coalition is there, which is Ryan White funded. The Kootenai clinics see patients with HIV. Dr. Ryan Gillis is a family doctor there who works in conjunction with infectious disease to care for patients with HIV. And then there is the Community Health Area of Spokane, or CHAS, which does not have Ryan White funding, but does have a sliding fee for patients to be able to meet their need, and then pharmacy and broad medical services. And then the Providence Internal Medicine Residency Clinic in Spokane also cares for patients with HIV. And then here in Southern Idaho, in Boise, there is the Emerald Clinic, the HIV Wellness Clinic. Dr. Stacy Lamers, who I mentioned, comes to Twin Falls as well, where we are today. And then multiple other expert HIV and viral hepatitis physicians there in the Boise area, and then case management as well. And they can certainly correct me if I'm wrong, but my understanding over trying to get patients connected there is to call the clinic and then also fax patient information, including their date of birth and labs, to the clinic. And in my experience, they've been really on top of getting in touch with patients, making sure they have resources as soon as possible, and getting them linked in with all the appropriate people and resources. So then we also in Twin Falls obviously have the wellness clinic that travels here from Boise with the help of Dave Hatchie, a pharmacist from Pocatello. And then Family Health Services here in Twin Falls, Dr. Canty sees patients with HIV, and they have newly hired a nurse practitioner who has HIV and antiretroviral therapy prescribing experience, so helping out there. In Pocatello, there's the Idaho State University HIV Clinic, and there are contacts there, nursing, medical case management. Pharmacist Dave Hatchie also gave me his cell phone number to share, but I don't want to be responsible for that. But I would just highlight that so that you know how eager and willing to be helpful he is, and has been working on HIV in Idaho and elsewhere forever, and is an amazing resource. And then in Idaho Falls, patients are also brought into the Pocatello Clinic, but there is a District 7 specific medical case management. And I include a District 5 here for Pocatello as well, just because it is possible to get patients in District 5 over to the east side rather than having to go in toward Boise if they're kind of on the eastern edge of District 5. And then we are our own resource as well, and we can stay knowledgeable about caring for our patients with HIV. And here are some options of how to do that. There is the University of Washington curriculum, which I find fun and engaging and a great way to get CME credit as well. And they have some additional prep curriculum and ways to become kind of like HIV care certified as well. And then they have a whole list of drug interaction apps, but you also have the University of Liverpool website. So I included an example here of if you look up cabotegravir, for example, with omeprazole, it's going to not only tell you if this is okay or not, but actually give you an explanation of why and what, guide your conversation maybe with the patient. Because if you're not super familiar and you don't have a script about talking about medication interactions with antiretroviral therapy, I think that's really helpful information to have. And then, of course, HIV.gov and the Idaho Health Department are great resources as well. So overall, I hope this leaves you feeling like these are attainable goals, getting more patients offered HIV screening and reducing the rate of late stage HIV to well below the national average, hopefully. Reducing the number of patients acquiring HIV because we're getting such good viral suppression, such great adherence to therapy and engagement in care. The more comfortable we are with caring for patients with HIV, the less likely they are to feel sort of stigmatized and separate and not wanting to engage. And then, of course, staying in contact with our helpful and capable local resources who are more than happy to engage and be helpful to you. And here are some of them. This is just great thanks to lots of people who've helped me in my education around HIV in particular. And any questions? That's all I have.
Thank you so much, Dr. Fox, for that important presentation. And it looks like Dr. Kern has raised his hand. Go ahead and unmute, Dr. Kern.
Yeah, thank you. Nice job, Dr. Fox. I, as much as anything, was just going to make a comment about how good of a reminder this is that we need to have it on our radar and be screening for it and frankly testing patients for it. I've seen in the last several years several examples of patients that have obvious and clear immunosuppression that did not get an HIV test until like a fair amount of time passed. So having that on our radars, screening people for it. The other plug I was going to make is for a while, we had a very motivated resident that was participating in what was called the Project Echo for HIV through the University of Washington. I'll put a link in the chat here of that program, but they have a lot of different options where you can, they usually have an education session and then allow doctors from around the WWAMI region to present patients and get input on the treatment and management. I believe Dave Hatchie has participated in that for a long time. And for somebody who was going to be in a more remote or rural place, kind of on their own, it's a really incredible resource to participate in and be able to bounce your patients off of, sort of an expert in that area, an infectious disease doc at the University of Washington. So I'll put that link in the chat. There's multiple different versions of that echo that the UW does. And that was just one more resource I thought of.
Thank you. Yeah, I think to what you were talking about in our not screening so much too, one of the things I've noted is we have our health maintenance tab in the St. Luke system, which has hepatitis C, but I've heard various reasons, so I won't speculate on why HIV is not there, but that's something that I think we sometimes rely on a little too heavily and need to remember that there are other things that are recommended for screening that don't pop up in our little red box.
We have a comment in the chat from Peter Ferrara that it was a great presentation. Thank you. And then Dr. Kern has put that link into the chat. Anybody else like to unmute or put questions for Dr. Fox into the chat? I'm not seeing any hand raises, but feel free to go ahead and unmute or type something into the chat. I'll give you another few seconds or whatever. Okay, well, Dr. Fox, thank you again so much. I just want to remind everybody, if you want CME for this event, I have dropped the link into the Google form and my email address if you prefer to email me so that you can get credit for the CME. We will send you your certificate and self-reporting instructions in the next month. Our next Grand Round CME is June 10th with Full Circle Health Nampa, and the presenter and title will be released via our e-news and other outreach soon. Dr. Fox, is there anything else you'd like to say before we close?
Yeah, no, I just want to thank everybody for their attention, and my contact information is here by email, and you know, there are people that will be much more useful to you to contact, but if you want help connecting to anybody or have questions, I'd be more than happy to help get you to the right person. Thank you.
Thank you so much. We're so grateful to you for today's presentation. I will be sending the link to the presentation once we have it on video as well when I send out the CME certificates. Appreciate everybody being here, and please have a nice day.
Thank you.
Thanks. Bye.